Natesh Parashurama, a physician, scientist, and a bioengineer. I run a research laboratory at the University of Buffalo, State University of New York, in areas of regenerative medicine with human stem cells, organogenesis, gene regulatory networks, and cell imaging technology. As Vish mentioned, I had the great fortune of working with Dr. Gambier, being on the train with him for 4 years at Stanford in the areas of stem cells and reporter gene imaging, as well as continuous sensing and monitoring, some of the things that have been mentioned already today. And I learned a great deal from Dr. Gambier, and I currently teach a course in molecular imaging as well. I'd like to now introduce our speaker, Dr. David Bluemke, MD, PhD from University of Wisconsin-Madison. Dr. Bluemke is a professor of radiology at University of Wisconsin School of Medicine and Public Health. He's editor of the journal Radiology, where I had the fortune of publishing a couple of my articles. He's currently I was previously the director of radiology and a tenured investigator at both NIH in Bethesda and professor of medicine at the Johns Hopkins University School of Medicine. His research has focused on early detection and diagnosis of cardiovascular disease with non-invasive imaging techniques, and particularly MRI and CT. And he's published many papers, over 700, and many books and book chapters on the topic. And now we would like to get Dr. Bluemke started.
Hey, good morning to everyone there. Try and get my screen shared. So I'm calling in from Madison, Wisconsin, as was mentioned. It's very much my honor to present at this symposium celebrating the life and career of Dr. Gambier. And I'd just like to take a moment. For me, Dr. Gambier was really the embodiment of new ideas, out-of-the-box thinking. It was always interesting when he was giving lectures, the audience was packed. Everyone was there to listen and to learn, and actually they were very excited about it as well. It's not so common in scientific presentations, but I think that was would characterize those lectures. They were the highlight of any meeting that I attended, and the interesting aspect for me also, it was a journey of innovation, but it was also logical innovation. We could move along with Dr. Gambier through these innovations and his journey. I think a big part of his legacy will continue to be that ongoing innovation. And clearly he's inspiring his colleagues at Stanford, but now additionally from around the world to do more and to do better. So for my part in the symposium, I'll be discussing a new CT technology called photon counting. And my disclosures are here. There's going to be investigational equipment for some of the slides as well. Okay, so we don't usually hear about innovation and CT scanning exactly in the same sentence that often. It's kind of routine for us. There are 80 million CT scans performed per year in the United States. It's one of the most commonly performed radiologic procedures. And you could say that our last prior fundamental development in CT was in 1990, more than 30 years ago. And that's where we went from one slice at a time to continuous scanning, which we now call helical CT. Well, that's certainly refined. 30 years is a long time, and there have been a lot of advances and refinements along that same principle. We've gone from one slice at a time, then we put 4 rows of detectors together and up to 320 at the same time. But the fundamental process goes back to the detectors that were used in 1990, miniaturization, advancement, faster, and so forth. So most of the time in our CT labs, it's an issue of sort of prescribing an X-ray dose at the right time according to when the iodine's there, a whole lot of post-processing. So the images are there, you're going to get more information by other mathematical processes you're doing in order to see what's inside the patient. That's what we're mostly doing. Let's go back and review a little bit about detection of the X-ray to begin with, the photon unit of energy. How is that done? The detectors, I'll just call them conventional detectors, but formally an energy integrating detector detects that photon by, after passing through the patient, it'll go into a detector system where the photon energy is converted to light. A little bright light, and that's detected by a photodiode, and an electrical current is produced. And that current is digitized. So the digitization occurs relatively at the end of this process. So with Photon CT, we're going to fundamentally rearrange this process, convert all of these steps into a single chip to count the number of photons and characterize their energy levels. So where did this come from? Where did this develop? Photon counting detectors have been around for a while, since the 80s and 90s. They were originally developed for detection of after high energy particle collisions at CERN. And this is one of their experiments. They were detecting 153 particle hits. They had a detector array size of 500,000 pixels. It's going to be the opposite of what we're going to do in medical imaging in some respects. But the main point that we're going to borrow from this technology is it's a digital assessment of the number of photons and their energy levels. So here's the whole kind of chip process that goes on. Besides the integrated circuit that's on this chip, there's direct conversion of photon energy to an electrical current. So X-ray beams come in, we have electrons forming in the detector material, drawn towards a pixelated anode. Now, as this happens over time, on the x-axis, there are different energies that are detected, and these can be thresholded into between 4 and 8 energy bins, depending on the detector chip that you're being using. Well, this system was installed at the NIH in our photon counting facility originally in 2015. And that was a very unique device because it had a combination of both the old system and the new in the same device, scanning the patient at the same time with the same X-ray source. So it was an incredibly good device to experiment on and see what these pictures are going to look like when you rip out the guts of the machine and replace the fundamental bits here that are going to detect and form the images. So this is one of the first publications, and everybody's around in the room. Everybody loves a car crash in a sense. We weren't really sure what was going to happen. I think we had 14 people in the room at the time, and nothing happened because it took 24 hours to reconstruct the images at that time. But eventually we got out, and kind of my concern, would we get anything? And fortunately, sometimes new technology is 2 steps backwards and then 1 step forward over time. But we're starting with photon CT images that look, really good. They are as good out of the box with an experimental unit as our conventional CT. And they were superior in some areas of the body that were quite difficult, and I'll show you. So given that baseline, what are the new things that this is going to accomplish for us using photon counting technology? Because we're going to start at where we are now. First, we could say that the radiation dose from CT is high. Every time a new device is released, it seems we're concerned about this. So I'll go over that. The next thing, spatial resolution is really too low for some of the things that we're doing routinely. We need more spatial resolution. And then spectral energy resolution. That's what the basis of the CERN detectors had, and the rationale for them. It's inconvenient, it's infrequently used. Okay, so medical radiation, point number 1, the bulk of that is from CT. So if you go to the FDA website, FDA is comparing CT radiation to survivors of the atomic bombs. The EPA is not a whole lot better, whole body CT being compared to living near a nuclear power plant. Why? Why is that? CT scanning, about 50% of per capita radiation exposure in the United States. You have one body CT scan, and it's at least 2 years of background radiation dose. And if you're sick, you're not just having one scan. The NIH patients get scanned frequently, maybe once a month for some experimental protocols. It's really add up. So the public's going to demand these questions. What about radiation? What are we doing? So here are some of the initial results with photon counting CT. Chest CT should be a relatively low application, low radiation dose application. And here's the results. This is based on body size. So obese patients to normal patients, fairly linear decrease in the noise that was achieved, better contrast to noise ratio, and overall about 30% lower radiation dose. Separate set of experiments, we turn the knobs all the way down. This is approximately chest X-ray level of scanning. Still, substantial improvement in radiation dose across the board for photon counting CT. So we can acquire much less radiation dose if we choose. If we need more, as in the case of the brain, for example, maybe stroke imaging, radiation dose match, conventional on the left, Photon counting on the right, substantially improved gray-white differentiation. We go to the basal ganglia, the anatomic structure and the ability to detect subtle lesions is going to be larger. But in addition, it's not just that, it's better accuracy in the density measurements of the CT scanner. This is the carotid artery going up towards the brain. This is the carotid siphon. And this is a very difficult area. This is in the petrous bone. And we can see that the iodine density has these low areas, and what that's due to, if you were in a critical situation, you'd say, well, maybe this is bony density there and some artifacts. And indeed, with photon counting CT, again, out of the box, these images substantially better, less beam hardening artifact. We can measure the density across that area. It should be uniform. And then green, the increased accuracy of the density measurements on photon counting CT are going to be on every application. This will result in really superior, better cine rendering and volumetric imaging with this device. Okay, so we have more efficient detectors, and we have elimination also of electronic noise because of the spectral capabilities. We can apply between 4 and some detectors up to 8 spectral gates. And this lowest gate is going to be used to eliminate essentially electronic noise. The others are going to be used for characterization of materials that are present. Okay, problem number 2, spatial resolution. Conventional CT, how do we get a better resolution CT scanner on our current device? Well, the X-ray comes in and there's a scintillating crystal. So the X-ray hits and it makes light. In order to accurately determine where the light is hitting on the array, there are reflectors spaced evenly along the detector array. And so, okay, so this positions the detector number 3. Well, let's get higher spatial resolution. We have to divide that into 2 parts. These reflectors have finite thickness. As you go to smaller and smaller spatial resolution, a greater amount of space is taken up by the reflector. This is a process you cannot win going this way, because as you need to add these reflectors, you're going to have to apply additional radiation in order to make the image to get to the photodiode at the other side. Okay, with photon counting CT, there are no reflectors in the system. The X-rays hit the crystal, create the photon event in the detector, detected by the pixelated anode, 100% geometric efficiency. Now, nothing is free exactly. This is hard to do. And as I mentioned at CERN, those experiments, there were 153 particles that were detected in that experiment. Here we're doing 200 million photons per second per square millimeter. And as a result, there's a phenomenon called pulse pileup. We can't really count these things accurately enough at these very high medical radiation rates. And so what's done? This is actually going to help us in the end, as long as you can afford to make these pixels smaller. If the pixel is smaller by half, your count rate is going to go down by half. Okay, so this is a pixel. Let's say this is a photon counting CT pixel and at standard resolution, but inherent to the technology, behind that 1 pixel is a 4x4 array of pixels. So 16 times the information flow potentially at some point in the evolution of the device. In our current device that we had, these were binned into 2 times array, 0.25 millimeter spatial resolution, but still within that, each little ray, 4 detector elements that at some point could be read out individually. So the easy thing we can understand, we want in radiology is an improvement in resolution. But another slide by Dr. Pelk from Stanford, he demonstrated the principle that for certain types of imaging devices, CT in particular, you acquire at this high resolution mode and go back and generate your standard resolution image, you have a better image. You have 20% lower noise just because you're acquiring at lower spatial resolution. And this is independent of that greater efficiency of the photon counting detector that I mentioned earlier. So we could get our conventional CT on the far left. We could acquire little pixels and reconstruct the same and have a better image just on that principle of the reconstruction process, or we could get this high spatial resolution image. But radiologists, once you go to high resolution, 4K definition, it's very hard to go back. Our eyes crave this. We just spent $10 billion on the Webb telescope, all about spatial resolution, what's out there. So some of these applications I think are quite clear to us already. Many of our centers, you're doing 10, 20, 30 coronary CT angiograms, and you're always wondering, what exactly is the detail that we're missing in these? Well, one demonstration, the treatment is a stent, and we can use this as a fixed diameter lesion to see what really should be there. These are conventional CTs, two different really state-of-the-art scanners. These are the stent and cross-section and longitudinally. This is the photon counting CT, of course, at the same spatial resolution, and this is high resolution mode from photon counting. In the middle, conventional resolution, and this is going to be the resolution and the fine detail we're going to see from these devices. Now, there are penalties. If you go to high spatial resolution, you're going to need to apply more photons. We believe that these can be mitigated largely by advanced reconstruction techniques, AI, and other methods. But in the lung, I think this is going to be very, very important. Most of the time, we're imaging late in the disease, water in the airspace. A lot of disease we're interested in on the conventional CT is originating in the bronchial wall, which for the most part on cross-sectional images is not visualized due to the small diameter, small thickness of that wall. Here's temporal bone imaging, which can become more routine, the imaging of stapes and small structures in the temporal bone. Okay, the last topic and what the folks at CERN were really interested in is what are the particles? What are the energy levels of the particles that are being detected? And this is called K-edge imaging. On our original iteration of the device, we had 4 different K-edges. The lowest was being used to eliminate electronic noise. But then we could apply K-edge in this animal model to around the gadolinium detection, iodine contrast, or bismuth, and here's the K-edge. So we can segment the energy levels. Conventional CT will show none of this, as shown here in this dynamic imaging. Well, we have RGB imaging here. This becomes true color imaging. It's no longer pseudo coloring that we use in every other area of medical imaging. We can see that the yellow color is a combination that can be quantitatively related to the amount of iodine, the amount of gadolinium. This is an animal model given some Pepto-Bismol for bismuth. We can see that in the bowel as well, very easily detected by this technology. Another example at the top, single energy CT, full color CT at the bottom. Detection of gadolinium, the time display and injection of gadolinium at this point over time, and the aorta coming in versus separate detection of iodine in that second injection. So we've done up to 4 contrast agents to date, and this is going to be kind of something that really needs to be developed over time with CT, but ultimately will give investigators a lot of opportunity for this. So I do think this is going to be a major clinical advance. Out of the box, it's going to be equivalent to conventional CT for routine applications, but it's going to offer substantially lower radiation dose with fewer artifacts, always on spectral imaging, and the potential for multiple contrast agents. I think perhaps oral contrast agents. We were doing experiments with colored embolization beads for interventional procedures to see what has been embolized. Those probably have the quickest potential for newer contrast agents in CT. But I think spatial resolution is going to be very exciting, likely to yield immediate increment in CT technology. This is a slide from Ron Summers at the NIH in my department when I was there, showing the desire and the goal to image everything, the smallest vessel in the body, which, finding in this case, this was a patient who was potentially being considered for a bowel transplant. But routine applications for cardiac, lung, bone, angio applications, I think, are easily thought of. I'd like to acknowledge my co-authors at the NIH and from many institutions and from Siemens as well for their support. And I'm going to stop there. Thank you very much.
Okay. All right. Thank you, Dr. Bluemke. We are taking questions. And at the moment, let's see. Yes, there's a question. Can you clarify whether higher resolution PCCT will require higher or lower radiation dosages?
Yeah, so that's kind of the fundamental thing. Are we just going to crank up the number of photons to get smaller pixels? I think it's not going to work that way. It can't work that way. I don't think it's feasible to increase doses. But right now, compared to even 5 years ago, we have a number of good options in order to reduce those doses. Out of the box, if you start cutting pixel sizes in half, The radiation dose is expected to be 2 to 4 times, depending on the body area. But I think largely this will and should be mitigated by AI reconstructions, by tin filters, low energy imaging, which will be more feasible. So my expectation is the applications that people will actually use and want to use will, at double spatial resolution, will try to achieve the same radiation dose levels, whereas conventional imaging that you don't really need that spatial resolution should have a substantial dose reduction out of the box.
Thank you. I have also a question for you. The multispectral capability seems like a really interesting and new kind of approach. Does that approach enable you to reduce the mass of contrast agents because you can do the spectral separations or distinction? Are you able to reduce the agents that are the doses of the agents, or is it going to be a conventional doses?
Well, I think for iodine, the answer is going to be probably not for iodine. Iodine is kind of a very inefficient contrast agent for CT, and that's what we use. That's pretty much all we have.
Yeah.
It's probably not going to be the case. I think the applications of contrast agent, the ideas that we were exploring, let's say in interventional radiology, somebody's getting repeated embolization procedures. Well, every time the embolization beads are being identified on the CT or the MRI, they're all bright. It's just dense beads. And so how can we identify one treatment effect versus another? Are the beads going to obscure the anatomy that we're looking for? So that may be one application of spectral imaging early on. I think also in terms of if you are trying to develop new agents, is it possible to reduce dose to detect those agents? That may be possible later on, but won't be an early application.
Okay. Any further questions? Let's see. Okay, there is one more. Actually, there's a couple more. All right, so we'll do it until we run out of time here. I'll do the next question. I guess the question was, what are the advantages of the technology described today, the photon counting, compared to spectral CT of Philips?
Yeah, the Philips is an interesting application. I would say we describe it as always-on spectral imaging. So the other devices out there that do spectral imaging, it has to be prescribed explicitly. So Philips has a nice technology. It's always there for you. One of the issues when you build a multi-layer detector system, as in the Philips scanner, you choose your energy levels, build it in the factory to those energy levels. Whereas the energy levels in photon counting CT are electronic levels that can be altered. You can choose whatever levels you want. We don't really know what the ideal levels are in some respects. So that won't necessarily apply to the first clinical devices. The manufacturer will probably fix those. But in investigational devices and in the chips, these are programmable energy levels. And it's going to depend on who's building the chip and how that can be accessed. But for example, we had 4 energy levels in most of our experiments. We would set those energy levels to whatever is desirable for the experiment that was being conducted.
Thank you. There are a couple other questions, but we are running a little late. So I thought right now, perhaps we should go to break. We have a 15-minute break in the schedule, and we will see you back. Thank you, Dr. Bluemke.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.